Welcome to RUMC Connections. The UroLift system is a minimally invasive procedure to treat an enlarged prostate. It is a proven option for patients looking for an alternative to medications or major surgery. It is the only leading enlarged prostate procedure that does not require healing, cutting, or destruction of prostate tissue. And then we also have aquablation, which we'll be discussing today. Aquablation therapy is a new type of surgical treatment for benign prostatic hyperblasia, which is BPH. And we discussed that a little bit in the last episode. We'll dive into that a little further today. And the Richmond Health Network is proud to be among the first in New York City to offer this advanced, minimally invasive treatment. So you don't have to leave Staten Island for these new advances. And let's kick things off talking about the prostate, what the prostate is, prostate health, enlarged ones.
An enlarged prostate, it's known as benign prostatic hyperplasia.
Okay.
And it's the most common prostate problem in men over 50. Mm-hmm. By age 60, about half of the men show symptoms of an enlarged prostate, and probably by the age of 85, 90% of men have symptoms of an enlarged prostate. Basically, the prostate's a small gland that sits below the bladder, and it surrounds the urethra. And as hormonal changes occur with aging, it causes enlargement.
And the prostate will grow to the day that you die. Young people can also have issues with their prostate, so it's not just a old man issue in regard to it, as many people think. To kind of clarify there, a lot of people think that the urethra and the prostate are two separate entities. Mm-hmm. In reality, they're pretty much the same once you enter the prostate. Patients come in and say, well, I don't want to do anything to my urethra, but we got to take care of the prostate. Well, they're the same thing. You can't really delineate them unless you put it under a microscope.
Okay.
But this is such a common thing that 1 in 3 men have this issue.
Wow. So now you say symptoms. What are the symptoms that people should be looking out for that would entail that they might have an issue?
Sure. I think the most common one is, their strength of their stream. They're not peeing like they were when they were younger. A lot of guys will make jokes about it. Oh, I'm just getting old. This comes with age. But the truth of the matter is there's something more going on there. Mm-hmm. Getting up more at night to pee, urgency and frequency with urination, which is, you're running back to the bathroom 20 minutes later, or you're doing the dishes, the water's on, and I got to run to the bathroom real quick. Okay. When you go to pee and urinate, it takes you a while to get it started. You kind of have to coax it out. Those are the big guys that we're looking at. And then the more important one is that you're not emptying out the bladder well. You go to the bathroom, you don't feel like it's empty at all. You're having pain. Those are the issues where men are not voiding well. A majority of the time that relates back to their prostate, which then ultimately relates back to their bladder and their bladder health.
I usually make the analogy to patients when I try and explain the prostate to them that the prostate's like a donut and it sits beneath the bladder, and the hole is where the urine goes through.
Okay.
And as the prostate gets bigger, the hole gets smaller.
Yeah.
So it makes the bladder work harder. Mm-hmm. And I think one of the big pushes that Dr. Wilson and I are kind of stressing to patients is that bladder health is really important. And, over time, the bladder can work harder and harder. It could get thicker and thicker, but sometimes it poops out and it starts to not empty you adequately. People leave residuals in the residuals of urine in the bladder, and sometimes may not be able to urinate at all and become catheter dependent later on in life if it goes untreated.
The big issue is if you're not emptying out the bladder, you can get recurrent infections, you can get bladder stones, and end up permanently with a catheter. Okay. And I think that's what a lot of people are fearful about.
So is the key to bladder health hydration?
That's a component, but it's making sure you get it out.
Okay, yeah. Is there anything else people could do to keep their bladders healthy?
See a urologist.
Exactly.
Absolutely. Okay, so if someone's coming to you with an issue with their prostate. Now, how do we determine whether UroLift might be a good fit for them? Talk a little bit about that.
So what we do is when a new patient comes to the office with symptoms of an enlarged prostate, we have them fill out an IPSS, International Prostate Symptom Score sheet. Basically, it's a questionnaire that looks at 5 or 6 different symptoms and grades the severity of the symptoms from 1 to 5. We get a score by adding up those numbers, and that categorizes the symptoms into mild, moderate, and severe.
Okay.
Okay, so that's the first thing we do. The important thing to do, the real reason why we do it, or one of the real reasons why we do it, is because we compare, see how treatment is working. So there's a big difference in the change in IPSS, the better the treatment is, or the more effective the treatment is.
Patient comes in, we can have the conversations about it, but it's very subjective. When you put a number to it, it's very easy to follow. When patients follow up, it may be a month later, it may be 3 months later, but if they were in severe and now their symptoms are in the moderate category or mild category, then what you're doing is working.
Okay.
When they come in, we assess the size of their prostate. We check a PSA to make sure we're not missing any prostate cancer. And then we do some testing to see how the pressure and the flow of their urination is. And then, ultimately the question is, how big of a prostate are we dealing with, and what the, size of it is. Measure twice, cut once if you have to, but not all prostates are the same. They're very variable in size and shape, and it's not a one size fits all mentality.
Right.
That makes sense.
Yeah, a big issue is looking at one of the big issues of the workup is doing a cystoscopy, which is look inside the bladder with a fiber optic telescope.
Okay.
It's a quick, easy test. It takes less than a minute to really look in the bladder, but it gives us a good idea of the shape of the bladder, which is an important aspect that we have to find out in order to determine what type of treatment may be best for patients. It also gives us an idea of the bladder health, and it can tell us, how hard this prostate and how hard and how long the bladder has been working against the enlarged prostate.
Right. And sometimes you look in there and the bladder looks like Swiss cheese.
Oof.
That's a bladder that's kind of really worked itself to death, if you will.
Yeah.
But at the same time, when we look inside, we see, is the prostate getting squashed from the sides? If you kind of think of a hot dog in a bun, you can push from the outsides, or you can kind of squish it from the top, or do you have all of the above?
Okay.
So you kind of look at that, you look at the size of their prostate, and you look at what their bladder status is. If they do not have a very good bladder, maybe a minimally invasive thing's not going to give them the best bang for their buck here, for lack of a better term.
Oh, yeah, of course.
So, once that workup's done, it's the conversation that we have with the patient of what are their priorities, what are their concerns. Some of the medical therapies out there that we use, Flomax, which has been on the market for a long time. There's finasteride or Proscar, which is another medication. Cialis is kind of one of the medications that can be used for erectile dysfunction and urination. Once you get out of it, there are different combinations of all of that, but medications all have side effects. The biggest one I think most men are concerned about is what's called retrograde ejaculation, which means after they orgasm, nothing will come out. It actually goes back into the bladder and they pee it out later on. But for most men, that is a concern, and there are other side effects that play a role there. And if medication is not an option, then we start talking about different procedures out there.
Yeah, so we have many different procedures that we can offer patients, and again, it's based on the size, shape of the prostate, and the condition of the bladder. They go from minimally invasive procedures such as UroLift. We have Aquablation, which is a robotically driven prostate resection. We can do open procedures. We can do transurethral vaporization of the prostate. We can do simple robotic prostatectomies, and we have a conversation with patients based on that, and we offer them what we think is the best treatment, which will give them the best outcome.
You treat a 100-gram prostate very differently than you do a 40-gram prostate. Shaving down the prostate, or most men will hear it as a rotor-rooter. That's what the most population understand it as. That's still available. We have something called prostate artery embolization, where for prostates that are bleeding all the time and that are really big, you try to decrease the blood supply to them. Data behind that is, you may decrease the prostate by 20% in 6 months, but it's variable.
Yeah.
Same with the medications. There's no magic pill out there that's going to reduce your prostate.
Of course.
That's everyone's biggest question. But I think in the realm where men who want to preserve their ejaculation and have a minimally invasive option, if they are a candidate, UroLift is a great option. There's Resume, which is injecting steam in there as well. When you look at our center, we are a center of excellence for UroLift, which Dr. Maggio accomplished in the past few years, and we continue to be a center of excellence for that. But we do offer a very wide range of options. Let Dr. Maggio talk about UroLift here.
Yeah.
Okay, so UroLift is a minimally invasive procedure.
Okay.
I like to do it for prostates under a certain size. we get the best result in a certain shape. Okay, so that's what the importance of the prostate ultrasound and the cystoscopy comes in.
Okay.
Basically, what we do is, if you take that donut analogy again, we go in and we put these implants in the prostate. They're like stitches that squeeze the lobes of the prostate to open up the channel. So the goal of any treatment for treating the prostate is really to open up the channel, and that accomplishes that. The results are immediate after maybe a 5-7 day, irritative stage because of the procedure. Patients are remarkably better, and I typically see patients within 3 weeks, and we get another IPSS, which is the symptom score that we spoke about. And on the average, my results are a decrease in about 60%, or an improvement in about 60% decrease in the score.
That's a great
It's
success
really
rate.
pretty remarkable. And it's interesting because the process that an enlarged prostate occurs is very slow. So people don't really notice how bad the problem is. And they come and see me 2 weeks later, and they're like, oh my God, this is amazing. And thank you so much. And it's really life-changing for patients. And that was the biggest impact for me, is that how much this really improves patients' lives.
Oh, that has to be a very rewarding feeling, because something like that it impacts everything. It's uncomfortable feeling, to restore that to their day-to-day lives has to be incredible.
It's always interesting when the patients initially come in and you ask them the questions, and it's kind of like a really weird question about the urination. And then they come back the next time and it's like, so doc, I've been thinking about everything you asked me the last time, and I think I have some answers to those questions now. Then they have a procedure like this, and sometimes they come in, it's like I'm 12 years old again. I'm like, well, a fire hose,
Yeah, that's amazing. So it sounds like it's a relatively quick procedure to do.
It is a quick procedure. It's under 30 minutes.
Okay.
Patients are out of the hospital the same
So an
day. And again,
outpatient procedure,
it's an outpatient procedure. And again, this is one of the procedures that will be moving to the office once we have our office renovated and have a surgical suite in the office.
Wonderful.
Definitely. And like I said before, it preserves the ejaculation. There's only a very small handful of procedures that do that. The other one that it can is aquablation. That is a very big sticking point for men. UroLift in general, like I said earlier, your prostate grows to the day that you die. So could you need a retreatment of it? Possibly, but you can always, it doesn't take any option off the table for you, which is the most important thing. So, you want to have as many options to choose from. Yes, there are risk benefits for every option, but I think the more options that you have, the better it is for you.
Absolutely.
Of course. So tell us a bit about aquablation.
Sure. So aquablation is a procedure that's been out for, I want to say, almost close to a decade at this point. Essentially, it's using a water pressure jet to resect the prostate tissue. The gold standard for a long period of time, and still is a transurethral resection of the prostate, also known as a TURP or a rotor-rooter. With that, you're resecting tissue with a hot loop, like taking a hot knife through butter, if you will. So what aquablation does is there's no actual hot knife or hot loop in regards to the resection of that aspect. What it is it's an ultrasound guided procedure. So you're under anesthesia. There's a probe put in your rectum, which identifies your prostate. There's a device that's put in through the penis, like a cystoscope, which is the fiber optic scope Dr. Maggio was talking about. And once that's in, we look at the anatomy of the prostate. And once it's there, we mark out the area we want to resect. So this water pressure jet, almost like a pressure washer, goes through and it actually carves out that tissue.
Wow.
And what it does is it has a zone in it called a retrograde protection zone, and we can modify that based on your anatomy. And in 9 out of 10 patients, it preserves it. For your bigger prostates that can be done, you can go in there and do that and still give them the preservation of it. Then we take that tissue out of there, we cauterize anything that's bleeding in a certain area, and then they usually have a catheter overnight. It usually comes out a few days later. The results for that, patients are doing very well. Outcomes have been really good. Erections are preserved. The IPSS score, almost a 16-point drop in their scoring system. Most of these patients, once they have it done, the chance of them needing a repeat procedure in their lifetime is very low. Now, in the next few years, Medicare will approve it for patients who have prostate cancer that also have an enlarged prostate. Is the newest word on the street in regards to it, which just opens up a whole new channel, for guys who have metastatic disease and they need, they don't want to be catheter dependent. They want to have a normal life function. But it's a procedure. It's fairly quick. It's actually quicker than a lot of other procedures from efficiency aspect and time. And RUMC just opened their brand new operating room and surgical area, which is a massive OR, and that's kind of where that's housed for us. Most of the patients that we've had and have undergone are actually quite happy.
They're very happy. It's exciting to offer these things to patients just because, in the past there weren't so many options.
Yeah.
Right.
But now we have a lot of options. And Dr. Wilson does, a lot of times we tailor treatment based on size.
Okay.
The good thing about aquablation is that you could use it for fairly large prostates when in the past you would have to do open surgery or other types of surgery. One of the other treatment options is the simple prostatectomy done robotically, and Dr. Wilson is doing that now here too.
Okay.
Essentially, we use the Da Vinci robot, and for men that have big prostates, or if they have big prostates and bladder stones, I can go in and take out the stones and take out a big portion of that prostate at the same time. The way to kind of think about it is, imagine cutting an orange in half, scooping out the inside, and putting everything back together.
Okay.
So men do really well with that. It's just another option in the armamentarium here. Some patients don't want to have incisions. So if we can do things through the urethra and give them the same, if not better, outcomes. I mean, I had a gentleman the other day, went to take out his catheter, and he actually peed the catheter across the room. I can't argue with that result.
Oh, that's so funny.
So, if you're seeing things like that
Yeah.
and the patients are happy and the sex life is what they want it to be, I mean, that's what we're here to do, improve patients' lives. We can take care of the big guys, the big prostates, the bladder stones. We still have the robotic options, but this is just a new robot and a new way, an option to go on, the way of doing this.
Yeah.
And the thing about it now, people are seeking that out. With the internet, people are researching before they get anything done and want to have those type of procedures.
Oh, absolutely. I mean, robotic, minimally invasive, it's definitely the way of the future. So for the aquablation, so they have an overnight stay typically with that procedure?
At this point, they're having an overnight stay. There are some institutions where you can go home the same day. It really kind of is dependent on size of the prostate and the person in general. A lot of institutions keep them overnight with some fluid running through their bladder, and then sometimes the catheter comes out the next day.
Okay.
Sometimes it's 3-4 days later. It's just every person is independent and different, so every case is different in regards to that.
Yeah.
Patients that Dr. Maggio has done and I have done have been doing quite well.
Yeah, they've done really well.
Well, I mean, I know with the UroLift, you're physically putting an implant in. With the aquablation, you're using...
It's just a water pressure jet.
Okay.
And what it does is when it goes through, it carves out the tissue, and then the tissue that remains in there sloughs off and dies off because of blood supply. Okay. If you look at these prostates a week later with a camera, you'll still see some of that. And then if you look at them a month later, it's much wider. And then if you look at them 3 months down the road, you're like, wow, I didn't even know it went that far.
Yeah.
On our website, we do have links to Aquablation. Aquablation does have its own website as well. And they have videos you can watch in regards to that. And you can see the difference. And it's dramatic. And I think the biggest push in their aspect is preserving the erections and the ejaculation. Most men afterwards, if those are preserved, they don't really know anything was done except their symptoms are better.
They're better. Now, once that tissue is removed, is there a chance that it could grow back, or once it's removed, it's gone and you don't have to?
Prostate continues to grow.
To grow.
But in a person's lifetime doing these procedures, doing a aquablation, you're taking out so much tissue, the chance of them growing back, causing them problems again is not so high.
Yeah, the retreatment rate for aquablation for patients, I believe the last number was under 4% retreatment rate in 5 years.
That's great. Wow.
So that's better than the gold standard operation, which is the transurethral prostatectomy.
Okay.
That was the classic operation that everything else was compared to. So these results are much better than that already.
As prostates grow, even the big guys that we take a big chunk out of this is, I tell patients, if you're 64 and you have a 150 gram prostate and we take out a big chunk of that, the chance of you growing back that in your lifetime, hopefully you live long enough that it happens, but nobody's got a crystal ball. But the chance of that having to be redone is much lower.
So if someone listening feels like they may qualify for one of these procedures, are these procedures covered by insurance?
Yeah, Medicare, they're covered by Medicare, which is really the one that guides everything else.
Yeah.
And the private insurers come on gradually, but most of them are all covered.
Prior to any of these procedures, the standard is you get a pre-authorization from the insurance company. If there's any issues in regards to that, our office works with that to try to take care of that issue. But for most insurance companies, from my experience, and I don't know Dr. Maggio's experience, it's well covered.
Oh, it's wonderful. I love learning about new procedures like this. Are there any other urological procedures that you hope to see in the future based on these advances in technology?
That question is countless. I mean, there are new procedures that come out all the time. There are 2 newer BPH procedures that have come out with balloons and something called I-10s, which is microcuts in the prostate. Those are fairly new, just kind of talking about hitting the market, getting on the market. It's an evolving field. Urology is one of those things that are usually at the forefront of the technology aspect.
I mean, when I was training, I would have never imagined that we would have had an oscillating power washer to resect the prostate. So,
of course. And RUMC is fortunate enough now to have this robot as well as the Da Vinci robot. So I can imagine this makes...
Yeah, I think there's a few more Da Vincis coming to the hospitals, my understanding, especially with this new OR we have.
Yes.
But in general, patients can stay in Staten Island. They don't have to go anywhere else where you can take care of them.
And do you guys have a most memorable case that stands out in your mind from all of these people that you've been helping and restoring normal lives to?
I mean, I am floored by the people who come in and are so helped by the procedures that we do. And it's really kind of rewarding to kind of get that, because you're impacting patients' lives, you're making them better, and they're happy. And really, that's really the goal of what we do.
I do have one case that sticks in mind. I had a guy who was in his 50s, younger guy, and he ended up with a catheter, and he had a 250-gram prostate. So I did a robotic simple prostatectomy on him. He had the catheter in to let everything heal for a few days afterwards. We took it out, and he was beyond ecstatic. When I tell you, he came in and he was just like, I can hit the wall. I don't get up at night. And he was like giving somebody their life back. Dr. Maggio, who just traveled to Africa, was doing the same thing. That option is when you give people perspective and their life back, it's a whole different ball game.
Oh, 100%. Absolutely. I can imagine, too, spoke about in your previous episode from your trip to Ghana, that there were some people that you must have.
Oh, it was amazing things. You know, people... It's just it's a life-changing experience, you know, for them to be able to get fixed.
Yeah. Did you get to do any robotic surgeries while you were there?
No, they don't have robots there. No, they don't have.
But that's wonderful that, you know, you've been able to.
Yeah, it was an interesting experience.
That's great. Now, we spoke about UroLift, we spoke about Aquablation, that these obviously are provenly effective treatments. Would you say that it's easier to determine you should get UroLift, you should get Aquablation? What's a good determination?
The size, shape, prostate is important in determining what type of procedure I would offer somebody. The condition of the bladder also plays a role. So there are a lot of factors that come in to play when you are recommending treatment for patients.
Yeah, when you come into our office, you'll see posters, and they're not just advertisements. We actually use the images on there to have the discussion. So, you know, it's a discussion about choosing the options, the risk and the benefits for every patient. They have to be willing for those. Some patients want certain things, and that's what their options are. We try to explain things as best as possible. So you don't leave our office panicking about things. You leave our office with a sense of understanding and being okay with what option you chose and what pathway we're going down.
Absolutely. Well, thank you, Dr. Wilson and Dr. Maggio, for joining me today and for all
having
that
us.
you do
Yes,
to
thank you
keep
for
us
having
safe
us.
and well.